At committee stage, a number of us stressed the importance of those sections of the bill relating to its application for prisoners suffering mental disorder. I continue to push to ensure that the parts of the bill that relate to the responsibilities of the MOJ in relation to the Department of Health aren't neglected once the Act becomes law. At committee, I focused on calling for a government review of the impact of the bill on prisoners, but listening to the thoughtful response from the Noble Lord, Lord Timpson, I saw that this could become yet another bureaucratic report. I therefore commend Amendment 38 from the Noble Lord, Lord Bradley, as an elegant way of ensuring that the crucial transfer to hospital within 28 days provision is more than an if-only paper aspiration. My Amendment 40, which I'm delighted is supported by the Noble Baroness Lady Bennet of Manor Castle, is also a practical proposal. It is designed to tackle problems that directly pertain to the bill broadly, because regardless of this legislation, the reality is that there will continue to be large numbers of prisoners suffering mental disorders who are incarcerated within the prison estate rather than secure hospitals. Then what happens to their mental health is the question, their mental health care when they are released. If this aspect is neglected, these ex-prisoners could well become increasingly unwell and deteriorate, and therefore in need of future detention. I think it would be a real mistake to neglect any policy or practice associated with this bill that fails to address the need for bespoke, ongoing support in the community, in which ex-prisoners' mental health is not allowed to fall further, creating new risks to both themselves and the public. And this is a real risk. Estimates from the 2023 report from the Centre for Mental Health, based on a survey of 75% of prisons and young offenders institutions in England, found that 1 in 7 prisoners receive mental health support while in custody, 1 in 4 amongst women. However, continuity of that care collapses after release. Research led by the University of Manchester recently found that 53 prisoners who'd been in touch with in-house services due to severe and enduring mental health conditions, that only 4 were in touch with community health services 6 months after release. The reasons are understandable why this happens, perhaps. When leaving prison, both the authorities and prisoners may well focus on practical challenges such as lack of housing, how to earn money and a living, and therefore mental health support can and does slip down the priority list. But leaving prison and it's also the case that leaving prison can present a shock to the system that affects this. Prisoners will be leaving a structured environment focused on routine and in many instances returning to more disorganised and chaotic conditions. Freedom may mean an arbitrary end to an effective course of treatment, maybe having waited for months or years even to access services such as therapy or specialised groups in which they've started to open up about traumatic experiences, all in prison services. Then suddenly, on release, there's an abrupt end to such support. So targeted interventions, prescribing regimes, access to medication inside are no longer guaranteed on the outside. I understand that ensuring continuity of care can be incredibly difficult. People leaving prison often have multiple and complex needs and can themselves be wary of accessing care in the community because of a lack of trust in state institutions. That means that they are less likely to proactively seek out help. Ex-prisoners also report that they fear that disclosing mental health challenges to, for example, probation staff will draw attention to their vulnerabilities. And then there's that dread recall, especially an acute fear for IPP prisoners, a fear of being sent back to prison if they appear too ill to cope, or a dread that other detention mechanism sectioning. So all that this amendment seeks to do is to ensure a smooth handover between prisoners and community services. Without such ministerial reassurance, I fear that this would undermine core parts of the bill unless it's taken into account. The stock reply to such concerns is that prison mental health services send on information to prisoners' GP. But in the real world, this is often a nonsense. Prisoners often don't have a fixed address on release, so they're just discharged with a medical letter. Prison nurses explain that they don't know where their patient prisoners will be released to beyond a hostel somewhere, making it impossible for connecting that person to even primary care. Prison-led medical staff also complain that often they aren't informed of the impending release until very shortly beforehand, sometimes a week or days, and this is especially acute in relation to the present early release scheme. So there's not enough time to set up appropriate community provision, to communicate with services, or even to conduct proper assessments of the individual patients before their release. Clinical needs are therefore deprioritised and prisoners fall through the net of statutory services. What's needed, and what this amendment envisages, is that a relevant detention authority is responsible for discharge packages that will, for example, register prisoners when they leave with GP services in precise area. A person is discharged can then liaise, to the person, GP services in the precise area a person is discharged to, and liaise with relevant third-party organisations and community provision to make arrangements. That is, that prisons and health authorities work together to prevent deteriorating mental health and a potential for behaviour on the outside that would mean yet more contact with criminal justice for the ex-prisoners and possibly emergency intervention and detention.